Hello, everyone, and welcome. This is David Harlow, and I am happy to welcome you to our Hangout on Air about patients' reviews of physicians, the wisdom of the crowd. Google Hangout on Air, presented by the Harlow Group, LLC, in association with the Society for Participatory Medicine. You can check out the Society's website at participatorymedicine.org. We'll start with some introductions and some technical notes, and then dive into our discussion. I am David Harlow at HealthBlog, Health, B-L-A-W-G. I'm a healthcare consultant, lawyer, and blogger with a keen interest in healthcare policy and digital health. I work with clients on the bleeding edge of healthcare on strategic and business and policy and legal issues, and as I like to say, I practice preventive law. You can find my blog, B-L-A-W-G, at healthblog.com. And that site links to my other online outposts, including Twitter, where you can follow me at healthblog. And joining me today are two guests, Niam Yaraghi and Casey Quinlan. Thank you very much for joining me today. Niam Yaraghi is a fellow in the Brookings Institution's Center for Technology Innovation. He's an expert on economics of healthcare information technology with a focus on health information exchange systems. Niam's research examines the network externalities in healthcare market and their effects on HIE adoption and use. His research is currently focused on analyzing outcomes of HIE use and reducing costs and increasing the quality of healthcare services. You can find Niam online at brookings.edu and on Twitter at Niam Yaraghi, N-I-A-M-Y-A-R-A-G-H-I. Casey Quinlan is a storyteller, a speaker, a media strategist, and a writer with an extensive background in broadcasting, theater, and stand-up comedy. She believes that business and life is all about the story. Casey studied theater and performance at the University of San Francisco, American Conservatory Theater, and elsewhere, and had a two-decade career in broadcast, network news, and sports. Just before Christmas in 2007, Casey was diagnosed with breast cancer, and she used this experience to write a book about managing medical care. It's titled Cancer for Christmas: Making the Most of a Daunting Gift, which became an Amazon bestseller. You can find Casey at mightycasey.com and on Twitter at mightycasey. Well, Niam and Casey have been posting quite a bit about patient reviews of clinicians over the past week or so. And for those of you who haven't done your homework reading, I'd like to bring you up to date a little bit. Then I'll ask my guests to help me fill that out more completely. So Niam began the conversation with a post that included the following statement. He wrote that since patients do not have the medical expertise to judge the quality of physicians' decisions in the short run and are neither capable of evaluating the outcomes of such decisions in the long run, their feedback would be limited, or should be limited in reviews, to immediate interaction with medical providers and their staff members. So instead of the quality of the services, patients would evaluate bedside manner, office decor, demeanor of staff. So this, he concludes, is why online ratings of physicians are not valid measures of medical expertise. So this, shall we say, inflamed the ire of Casey as an engaged patient and patient activist who noted that many patients with chronic conditions are in fact more expert in their condition and certainly in the ins and outs of their particular situation and what works or doesn't work for them in managing their condition than a clinician might be who is new to their case. There's an often cited statistic that it takes 17 years from the time new medical science is published in a journal to filter through to accepted everyday practice in the clinical setting. And an engaged patient who has a specific condition may be more on the ball about picking up information like that and bringing it to the clinic than a clinician who may not be facing that personally. Now, Niam followed up with another post noting that while some patients may in fact be experts in their own conditions, others may not be, posing essentially the question of how do I review the reviewer? How do I evaluate the reviewer? And this is a problem that should be familiar to any one of us who shops online for anything. The key issue he raised in his follow-up was this, though. An instrument is valid when it measures what it was intended to measure. So we need to figure out if we have instruments that are measuring things that we want to measure and how those work. He notes some studies that have concluded that patient satisfaction is not necessarily tied to improved clinical outcomes. My reaction to that is that there are a whole lot of things that are not necessarily tied to improved clinical outcomes. Think about the reaction of top-tier medical centers every time some ranking is published showing that they're not really at the top of the rankings. They're lower in quality than some other provider. They often react with a statement that's some variation on the theme of, we serve sicker patients, so the measurements are skewed, the results are skewed. Well, Casey, in her follow-up, confirmed that she's not suggesting that patient reviews should be the sole metric guiding clinician choice, so I think we have some area of agreement here, folks. But what we need, I think, we all agree, is we need better metrics to guide choice of providers. For all the hoo-ha around open data from HHS and elsewhere, 5-star quality ratings, PQRS, and the rest of the alphabet, these don't necessarily enable us to better answer the question, what doctor should I go to? So that's the question that I hope we can dig into today. What are the tools that we have at our fingertips, at our disposal today, and what are the tools that we ought to be building together for the future to better answer that question when we need to, because when we want to answer that question, we want to be able to answer that right away. What doctor should I go to? So, Niam, Casey, I hope I've framed the conversation thus far accurately. I invite you to jump in, and Niam, I'll ask you to start.
Well, thank you, David. Before I start, I just want to clarify one issue, and I urge all the viewers to go and read my previous blogs and writings about the role of patients in the medical care. I firmly believe that patient interaction with physician and their feedback about their overall health status is instrumental in providing quality medical care. As a matter of fact, I do believe that medical care is a service that patients have to be involved with as main co-producers of that service. So unlike most other services, like the food that you're served at a restaurant, which is solely provided by one provider, which in this example is the restaurant or the chef or whoever is that is preparing the food for you, your medical care is a service that you as a patient have to actively get involved and basically co-produce that with your physician. So there is only a limited amount of time that you're spending with the physician, and there is only a limited amount of things that the physician can do for you. And when you leave the doctor's office or when you're discharged from the hospital, then it is you as a patient who have to involve in your own medical care and basically help the physicians help you by a variety of things. That the easiest ones is to comply with the medical orders that they have provided, and the other things is to report back to your doctors and engage with them and make sure that they have understood everything that you're saying. There are many different efforts in the information technology area that are designed in helping patients to become more engaged in their medical care. Open Notes is one of them, and I think we all now know that engaging patients in their medical care is only going to help both the patients and the providers to achieve better results. However, I believe that when patients review physicians, they lack two things. The first thing is that they do not have standard and traditional qualifications to judge the medical decisions of a medical professional. Although it has sparked a debate and put off many people, but let's believe it, in the medical system you have to have an MD in order to be able to make medical decisions. The second thing is that because medical services are a complex kind of service, and there are a host of different factors that affect a patient's health, in addition to the medical decision that a physician has made, then it becomes really difficult for the patients to parse out the pure effect of that medical treatment that the provider has provided to the patient. In other words, it becomes really difficult to say whether it was the patient's family emotional support, whether it was treatment A that he got from another physician in the team that has provided care to him, or it was specifically this specific decision that this specific doctor made during his or her care process that has helped the patients. So although I believe that these engagements between the patients and physicians are really important, I am not sure if patients are still qualified and capable of providing feedback on the quality of the decisions that physicians made. It was brought to my attention that, a lot of patients are experts in their health. An example that was brought on Twitter was somebody said, what if I'm an oncologist and I'm diagnosed with cancer and I have to go to another oncologist for medical care? So, I have the standard and traditional qualifications required to judge the decisions of the other oncologists. Well, these are only a small fraction of the general population of the patients, number one. And although many patients may be experts, may even sometimes know better than their doctors, those are only a minority of patients when compared to the total population. And the second thing is that there is no credential system. I, as an outsider, cannot verify the claim that a patient may know better than a doctor, because I don't have any way to know it other than the claims that the patient makes. And I think one of the first things that the community of expert patients should first resolve before that they can claim is to have a proof for their claims. It's a very sensitive issue and hits the nerves of many patients. But we have to put our emotions aside and rationally think that how we can show our expertise, how we can provide proof for that, for the sake of other patients, to be taken more seriously, and to help other people like Niam, who just reads the reviews online, have a sense about the level of knowledge that Casey has as compared with some other patient who honestly may know nothing about the medical condition that he or she is diagnosed with. So I think I had to clarify these two things, and I'd be happy to hear what Casey has to say.
Great. Let me turn it to Casey in just a sec, and just observe that we regularly rely on reviews by quote-unquote non-experts in other fields, and each of us has a filter of some sort through which we view and digest these reviews. But Casey, let me turn it to you about as we kick this off. Go ahead, please.
Okay. Well, first of all, you can't use a service economy analogy to open. In other words, talking about like food, etc., and then flip it so that it's still a patriarchal paradigm that you don't know enough to say anything, you got to prove it first. My position around the reviews, I will make it clear right now that I do not think that Yelp reviews are in any way a valid standard for a patient to use to go out and figure out whether or not they should see this doctor or that doctor for something that they're confronted with, be it cancer or just a need for an annual physical. However, I will say what is available to us on any kind of metrics, around outcomes as to whether or not, yes, we can see where this person, MD, whatever, went to school, what kind of degrees they have. In some cases, we can see, their maintenance of certification stuff. But there's no real way that I have discovered to reliably predict whether or not this is, like the reincarnation of, Marcus Welby or, whoever the favorite TV doctor, Dr. Doug Ross, whatever, or Dr. Hodad, Dr. Hands of Death and Destruction, that Marty Macri introduced the world to him, but I don't know if that's a Macri invention, Dr. Hodad. But, I mean, how do you really know? This is a problem that when I talk to clinical experts, doctors, they have trouble. I mean, obviously there's the back channel, sort of the telegraph, the industrial telegraph where everybody can talk, behind. It's like, oh, watch out for so-and-so because he's dangerous, or watch out for so-and-so, she's got a problem, or, whatever. There's really no public-facing way for people to get reliable information. So, yes, in some cases we are stuck with Yelp reviews. There are things like PQRS, and you can look at Physician Compare. There are tools on ProPublica, which I love, but most of that stuff is Medicare related. It's Medicare reported data. I challenge you to find a pediatrician in any of that. If you're a mom looking, if you're a pregnant woman or a woman who's considering starting a family with her husband, or not, but anyway, considering starting a family, going out and trying to find OB-GYN information about, cesarean rates and, other issues. You have to kind of pack a lunch and spend days looking for this stuff. I'm waiting for the industry to start serving up some actual, actionable, understandable, parsable metrics out of all of this data that healthcare is spewing out constantly. And by the way, that's our data, not like, the industry's. It's patient data that we are kindly contributing to everybody's, whatever. But, as long as you're going to talk about health information exchange, you're going to talk about clinical expertise, you also have to start addressing the clinical quality and outcomes piece in there. And as I know from some of the work that I do, yes, I'm a college dropout. I don't have letters after my name, but I am not. But I'm also not that unusual in that I have just gone head down and learned all this stuff. Because in order to really create a partnership with a care team, and I had to do this when I was a family caregiver. This was long before I had to become an advocate for myself. I was an advocate for two elderly people as they aged and dealt with a whole bunch of neurological fun that I became an expert in Parkinson's. I became an expert in pituitary adenoma, surgical revision, and long-term care aftermath. I got to the point where when I was managing, advocating for my parents in the 90s and then actively managing their care, 15 years ago, that I'd show up and start talking. All the nurses thought I was a doctor. Most doctors thought I was a doctor. And I would say, no, if asked, no, I'm a really fast researcher and I'm a trained actor. So I'm good at showing up and acting like I've been here all the time. And that I know the secret handshake.
Yeah, right.
But,
Casey, let me ask you, how does that translate? How do you...
Well, I'm getting there.
Sure,
I'm getting there. So, but, the physician side has, their set of specifics. It's like, yes, I have an MD, and I've maintained certification in pick one, and, this is my credentials, and, so trust me. Well, okay, what evidence do I have that you actually have not fallen down on understanding what standard of care is? How do I know that you are not necessarily like the worst thing that could happen to a cancer patient? I've had personal experience with people who are listed as, like being the top of their profession that were kind of a nightmare. So, no, I haven't reviewed any of them on Yelp. But when will data that is actionable and usable by patients on quality and outcomes be available? I'm waiting. When will it be here? Until then, how are we supposed to determine, short of, like, sort of the, calling it the, sort of the back channel telegraph, how, that's how we exchange information. Not all of it is in public on Yelp. Some of it is in public on Twitter, but we don't tend to name providers. That's, always in the, in the background, not in public, because none of us really like to. Nobody wants anyone calling David to say, I need to sue this guy because he's trashing me on Yelp. I get that, but I mean, where are the metrics we can use? I'm perfectly willing to show up and offer up some ideas about a credentialing program for patient reviewers, but I think that's 10 miles down the road. Right now, where we are today, we don't have any actionable metrics or any quantifiable way of measuring whether or not a doctor knows what he or she is doing and whether or not he or she has a problem. Yes, you can go to the state medical board. You can, but again, you have to pack a lunch and then you have to learn how to understand what they tell you. Why is that such a problem?
Right. So what's the analog here? I mean, we have credentialing procedures. We have some physicians in revolt against continual credentialing and recredentialing of certain sorts. And the question is, we say we need quality and outcome data. Some of that is available now. Some of that is not necessarily being collected or made available publicly. It may be made available to certain folks in the food chain here, but not to everyone. What are the metrics that we're looking for? Because as we started at the beginning, while I think the three of us could agree safely now that we're not gonna choose a clinician based on a Yelp review, the question becomes, in the absence of uniform perfect data that we would like to see, and maybe we can talk about what that data set should look like in the future. Today, how do we choose a doctor when we're sick? I mean, Casey, in your example, how would you translate your experience in researching care and care providers for your folks into a framework for a recommendation for a patient dealing with something today?
Well, it was all the mistakes that I made, learning from my mistakes when I was dealing with my parents' issues, that turned me into the very proactive patient that I was when I was diagnosed with breast cancer. Mm-hmm. However, I did have the opportunity to observe my parents being e-patients before that term was even coined, and particularly in the 80s and 90s. But I mean, at a certain, really, the relationship between patients and the doctors that they go to, and NPs, et cetera, because you said MD, don't forget the NPs. They're allowed to give medical care too. But anyway, you kind of have to go with your gut. You're left with your gut. You go in, and you've got maybe some set of information that you've gotten from lab tests, scans, etc. You've got some news, and maybe it's not good news. So now you have to write your own decision tree. There can be help for that. Smart doctors, the doctors that I consider smart doctors, help patients do that. In other words, if there are other specialists they need to see, there's the whole referral concept, and then there's the second opinion, etc. But when you're getting down onto the primary care side, how do you do that? Again, you just kind of have to go with your gut. You have to go in and obviously look at the stuff on the wall, look at their credentials, figure out whether or not they know what they're doing based on your own information. Wouldn't it be nice if there was like reliable intel data, like how many patients, how many procedures that guy or gal has performed, what their outcome was? In other words, how many infection readmissions, the hospital that they go to, that they do their surgery in? What's their score? Granted, I'm going all over the map here, but the problem is there really isn't any scoring system that people can see. So you kind of got to go with your gut and then talk to the people that you know who have walked your path and find out what their question set is. I kind of go in like Mike Wallace. I go in with a list of questions. Hello, this is your 60 Minutes interview, doctor. If you can answer these questions, then we're going to do business. But
so
you got to do it for yourself.
Right. So I guess the question is, I mean, is it possible to move beyond the anecdotal? And in one way of asking that is there a master question list that we should be using? Another way of asking that is, are there measures that we can identify? And God knows we have enough measures in healthcare that we use for various things. Are any of these quality measures that we keep tripping over really useful in assessing quality and in translating assessments of quality into a language that's usable not only by clinicians but by patients? In my home state, the People's Republic of Massachusetts, or the former People's Republic of Massachusetts, we have a whole lot of measures that are mandated at the state level. Here and elsewhere, there are things like C-section rates that are reported on a facility basis, so people know going in, oh, I'm going to hospital X, the C-section rate is such and such. I can go to hospital Y, where the C-section rate is much lower. Maybe I want to think about that before deciding where and how to get my health care services. Niam, I want to bring you back into the conversation to talk about, are the myriad measures that we have at our disposal useful in this conversation? Do we need to start from scratch? Are there some sort of meta measures? I'm always on a search for like 6 good measures that could sort of predict everything else in the healthcare universe. What do you think? What are the chances here?
I think some of the measures for some kinds of medical providers at least are partially available. So for hospitals, we have the measures that you were mentioning, like readmission rates or mortality rates, at least for the Medicare portion of their patients. Although I completely agree with Casey that we need more data, we need more reliable data, and we need more understandable data. I think the community of expert patients is a gold mine that unfortunately is untapped. Although I said we don't have a system for verifying the medical expertise of these medical experts, I think we have to make it. And this is a task that the community of the medical, the expert patients should deal with. You guys should sit together and decide how you can parse the good from bad, how we can decide who is a true expert patient and who is not an expert patient, and then that credential system would be really valuable for not only the medical community, because now they know whose feedback to value more, but also for the general patients population, because now they are going to have a more reliable kind of outcome data from patients who know what they are talking about.
Yeah.
So that is the first one. If you're talking about more reliable measures, one of them is the wisdom of the crowd, and it's no-brainer that if there is a source of data, why not use it? So I do believe that expert patients have a say here, and for them, the first task is to prove their credentials and go from there. The second thing is, over the couple of recent weeks, I became aware of the power of Twitter and the expert patients on Twitter. And the other interesting thing is the other people who can really help you with providing more reliable outcomes data are also on Twitter. You know, Chief Technology Officer of White House, of CMS, and HHS are all on Twitter. So I think one of the ways to push for more reliable data on outcome measures and measures of clinical expertise of doctors is to let them know about your presence and to let them feel the demand from the patient side. Although, I would like to take this opportunity to also applaud CMS and HHS for their efforts in releasing data to the public and being more transparent than ever. So this is the second thing. And then there is another way of using patient reviews, I think. And that is, although we tend to refer to medical professionals as the ones who are the final decision maker in the medical system, we also have to admit that the complexity of the medical services is on a continuum from very simple kinds of medical services like administrating a flu shot to you that anybody can do it. You don't need an MD degree to be able to, give me a flu shot, to very sophisticated and very complicated kinds of medical services like, I don't know, a brain surgery and open heart surgery, which you have to have the medical training in order to be able to perform that. And I think in this continuum, the capability of patients to evaluate the quality of the services also changes. So if there are basic and rudimentary medical services, patients are more capable of providing feedback on the clinical quality of the services that they receive. Whereas on the far right side of this continuum, where the medical services become more complex and more complicated, then patients' capability reduces. So one of the very first baby steps is to use the patient's feedback on the very basic kinds of medical services. So if you want to choose a primary care provider for your annual checkup, then maybe online reviews are not the worst thing out there, especially when there are no kind of other reliable data. But when you want to, choose between two oncologists, then I think it's the time to think seriously about serious outcome measures that can help you make a better decision. And then I want to conclude my thoughts by one thing. Look at other industries. They try to provide rankings and outcome measures in the most simplified way. A popular example that you also mentioned is the college rankings. They are based on a host of different factors. But on any website that ranks the colleges, you just see the final ranking. And that makes your life very comfortable and much easier, because now you don't have to compare different kinds of colleges based on different kinds of criteria, and you have a final aggregated measure of the quality of that college. It becomes more important when you think about patients and the emotional status that they are at when, excuse me, I think that lights went out. Hold on a second.
Well, they're saving energy. I'm glad to see that. Nobody moving around in the room, it all turns off.
Yeah.
Wave your arms more, dude.
So when you think about the emotional status that patients are at, I think the last thing that they want is to be provided with 100 different measures of clinical outcomes and tell them, between these two doctors, you have to take a look at these 100 different measures and then decide on your own that which one is better. So I think outcome measures are definitely something that we need, are definitely something that are missing, and providing them to the patient population would really help us. However, we should think about providing that information in an understandable and easily comprehensible format for the general population.
Of course, I think there's no argument there. As I said before, one example is the C-section rate for births. The issue, I guess, that I'd like to pursue is the question of, are people able to make these decisions? Yes, it would be nice to have more data. Yes, it would be nice to have more data presented more understandably, et cetera, et cetera. Part of the issue is what will make providers communicate this information, even if we had the framework for developing and distributing this information. We've seen this kind of issue again and again. From a patient perspective, we often feel knowledge is power, and sometimes knowledge and information is withheld, and it seems like a power play more than anything else. Mm-hmm. So there's an issue about getting information out. There's an issue about, I included in the title of this session, and Niam, you mentioned the phrase as well, the wisdom of the crowd. We do rely on the wisdom of the crowd in a variety of different instances, and I'm not convinced that the expertise required to deliver the service negates the value of the wisdom of the crowd in evaluating the service. We're talking about evaluating a number of different dimensions, and I just don't want to necessarily kick to the bottom of the pile the notion that there is value in the wisdom of the crowd and in the evaluation that can be done. I've talked enough. I'm going to ask you folks to jump back in. Casey.
Yeah. Well, first, somebody's not yelling at me, but there was a response in the question stream, pushing back on my go with your gut. I'm not saying that going with your gut is in any way a great way to make a quality decision on what you think the outcome might be with provider A versus provider B. However, that's what we're stuck with right now because there are no actionable, easily parsable metrics for patients to use to line up to do any kind of a comparison shop on doctors beyond perhaps your basic primary care. But if you're looking for an oncologist, like, okay, what? I'll offer and of course now we're going to go anecdotal again. But one of my favorite e-patient stories is e-patient Dave DeBronkart saying that his doctor prescribed ACOR, the Association of Cancer Online Resources, ACOR, which is now turned into Smart Patients. That was how Dave found out, got the information on the treatment that saved his life. His own doctor didn't know about this treatment. And, that's Dave's story. He can tell it. But that's, this is why, and to David's point about it's a power play on what kind of information is made available, this is where that, the 17-year thing that was mentioned earlier about how it takes 17 years for known science to arrive at the point of care, that's a long time if you think about 17 years. And I think that we're all talking sort of around the same compass points, but I think the hub of this wheel is actually releasing data that is meaningful in helping people make these decisions. And as far as patient expertise goes, I think that the Patient Voice Institute, which is still a developing thing, but I know about that because I'm sort of on their advisory board. But the Patient Voice Institute is one place that's looking to create some sort of sort of quality assurance metric around patient expertise. I think that the Society for Participatory Medicine, even though it does not itself have any kind of a, like you get a badge and you're an expert if you answer all, take all these tests. I mean, I personally have a certificate from the the Armstrong Institute at Johns Hopkins around patient safety that I earned on my own as a patient. So if I end up in the hospital and I'm not unconscious, I'll be able to spot quality issues and report them based on expertise. But the bottom line is that I really think that there's not enough information made available to patients. That yes, patients. One of my central messages when I talk to patient communities is that sooner or later you got to just surrender to the process. It's you can't you can't do your own brain surgery. Don't even think about it. But what you have to do is learn as much as you can about what you're facing and who you want on your team. And then once you've done all that, you just got to kind of go with it because you're not in charge anymore. You're in charge of answering questions. But patient preferences are so important and so not usually taken into account that the only place where our voice really can be registered is somehow in public or in our communities saying Dr. X is awesome, Dr. Y is Dr. Hodad.
Right. So we have the patient perception of quality. We have the communication aspect. We have other aspects that may go into this, and I guess a couple of the questions that have come in are questions around, is this information useful? And we know there are survey tools that are used that have some significant rigor attached to them, the HCAHPS kind of surveys, things like that. And, it's useful for one piece of the puzzle, but I'm thinking, or want to explore with you, does that piece of the puzzle inform other pieces of the puzzle? If quality in communications is there, does that relate in some way to quality in other aspects of the experience? Can we rely on that in some way?
When you say communications, you mean the fact that they have delivered a survey or survey sections around communications?
I mean survey sections around communications, and I also mean beyond. Let's go beyond communications. Sort of the experience. These surveys are all around the quality of the experience, and we know that some of the folks in the hospital industry brought in folks from the hospitality industry at different points in the last several decades to sort of work on the customer experience, the guest experience aspect of the hospital stay. That's not medicine, but it's not something that needs that we can sort of dismiss out of hand. It all goes to number one, the experience, but number two, as you alluded to, Casey, the quote unquote guest experience includes things like infection control, and we all know that hospitals are places that you probably want to avoid because there's sick people in hospitals. So how do we blend all of this together until we have those half a dozen meta measures that I'd like to have one day that can inform us better about quality?
Oh, I'll just jump in. You can count on me. But I honestly think that just recognizing that patients have, patients know stuff. To quote one or the other of my two posts about this. Patients know stuff. I applaud hospitals using the HCAHPS survey, but I don't think that gets as granular as it needs to about individual physicians. And I also think that hospital outcomes need to be reported per physician. In other words, I want to know exactly how many of X that doctor has, done in that hospital, and I want to know, what the outcomes metrics are. I also would like to see more outcome metrics focused around what the patient's desired outcome is, as opposed to just the clinically defined alive, dead. Because a lot of outcomes, it's just like, oh, he was still alive when he left the hospital. That's a win in our column. Well, what about quality of life? And what about ongoing issues that surgical side effects, etc. But I think that there needs to be a more multi-point conversation where everybody's voice is equal, as opposed to one group saying, well, so we have all the scientific facts, whatever, and then every once in a while we get a little signal from down here where somebody says he died, but we're going to ignore them.
So, Niam, what do we do here? How do we work to get to a point where the folks who are in charge of developing quality measures and adopting them and using them in the system can incorporate patient issues in the metrics themselves?
Let me tell you why we have not been able to do it so far. And I think the only reason that those metrics have not been developed and have not been at least released to the public is because patients, honestly, are not the customers in the healthcare system. Patients are the widgets that go through the healthcare system, and those doctors and nurses perform some tasks that are ordered by the insurance companies on those widgets. So they were not worthy enough to be provided with the metrics. And this notion is now hopefully and thankfully changing. Now, patients would have a say because because the way that the physicians are paid is being different. So now it matters how well they are performing their tasks, and the patients should and would be informed about those quality metrics. This is the first thing. The second thing about the HCAHPS, your question about whether or not it informs about other kinds of outcomes, I would say at least there is no evidence that it does today. I mentioned a couple of studies in the blog post, the second blog post that I wrote, in which the researchers were looking at the association or correlation between HCAHPS and those few measures of clinical outcomes. In some of the studies, like the one published in JAMA Surgery, there is basically no correlation whatsoever. And in some other studies, namely the one by Bartok in DMJ Quality and Safety in 2013, there is some weak correlation between HCAHPS and some measures of clinical outcome, namely readmissions due to heart failure and readmission to pneumonia, and there is zero correlation between HCAHPS and some other measures, namely mortality rates from heart failure, or very low correlation like negative 0.13 between mortality rates and MI. So I would say we don't know. The question that you are asking is a valid question. It's, of course, good to know if there is anything about clinical outcomes that we could learn from patient surveys, but the research so far does not have an answer for that. What we have is they are either not correlated or they are correlated very weakly. So unfortunately, there are hospitals in which doctors and physicians kill you with a smile on their face. And You think they're doing a good job, but they're not doing a good job. And at the other hand, there are some grumpy old doctors who don't smile at you, who don't maybe listen that much to you, and but they're doing a good job.
Yeah.
So there is not a strong correlation between these two measures.
So let's bring this back full circle and think about patient ability to review a clinician on quality, not just on personability and decor of the office and so forth. And I'm thinking of an example where a patient with a chronic condition has gone from clinician to clinician, and I'm sure each of us can think of a real-life example in this vein, where clinicians 1, 2, and 3 either misdiagnosed or mistreated the condition, and we get to clinician number 4, and clinician number 4 says, oh, this is what you've got, and this is how we're going to treat it, and guess what? The problem is solved. Patient is then in a good position to provide a clinically valid review on clinicians 1, 2, and 3. I had condition X. These folks missed it.
Yeah.
But I think there's so much noise included in that signal that the overall evaluation does not inform. And that is why there is no correlation between these outcome measures and patient satisfaction survey. If it was the case that you're saying, which is a valid example, then you would see a much stronger correlation between these two. So although in those patient satisfactions, there are examples like the one that you said, those patients who were suffering from a medical condition for such a long time, and honestly became real experts in what they are diagnosed with, and then they went to a new medical provider who treated them very efficiently and did a very nice job, and now they come back and say, hey, I went to these 3 physicians first, they didn't know what they were doing, but the 4th physician helped me, and now I feel much better, and thus those first 3 are not as good as the 4th one. Yes, those instances may happen, but it appears that those instances are not the majority of the instances. So in most cases, unfortunately, the patients don't face such scenarios, and the feedback that they're providing does not correlate with the clinical outcomes.
So how about let's go back to the sort of the expert patient scenario, because I'm trying to hone in on things that are valuable in the patient review universe and think about how we can generalize it to a broader universe of patients. So that, I mean, the example I gave is maybe valuable, but your point is well taken. This is maybe a small percentage of patients and clinical interactions. Other situations could be the informed patient, the engaged patient who is an expert in his or her own condition, who sees a clinician and is able to evaluate the clinician on that person's understanding of current research, openness to sitting side by side with the patient. Let's look that up online. Some clinicians will do that in an office visit, others will not. And the yield of that kind of interaction can often be a positive for the patient. So what are other kinds of scenarios? Help me out here. What are the kinds of things that we can dream up that can yield measures that we can use in reviews and that also become more generalizable to clinical interactions as a whole?
Well, patient-side checklists would be really helpful. And this could get broken down into individual specifics around specific conditions, sort of general practice or expert rheumatology. Pick one, endocrinology. But I think that that's something that those of us in the patient community have been talking about for a while. I mean, I've created my own sort of half gag checklists, not really a joke. I mean, they were authentic checklists but they're very basic and mostly just to open conversations between patients and their doctors, that it's like, oh yeah, let's create a partnership instead of having this thing where I go in, tell you 5 things, you know, like type a lot on a computer with your back to me, and then you give me a whole bunch of papers and tell me to, you know, start, you know, exercising more, and then you know, I go and it's like, what? Or hospital discharge is even more fun. You know, a checklist for patients to use in hospital discharge. I mean, I think some hospitals have started to create that kind of tool, but helping the folks on the ground, the patients, and the doctors and nurses that they work with come up with some, you know, some good, reliable self-metrics, if you were. It's like, these are the things that I need to ask to know that I'm walking away with what I need. And yes, my doctor, you know, or the nurse gave me all of this, so this was a successful exchange that I will give a 5-star review to. I mean, but you know, on the flip side of this, there's a lot of patient-reported data in feedback forms, whether or not it's HCAPS or, you know, whatever, whether or not the hospital is even involved. But there's a lot of feedback given to the system that is then swallowed by the system, kept inside it, and never revealed again. There's a question here about neurosurgery and the question thing, about a hospital that was asked a direct question about one prominent hospital flat out refused to answer a question about whether they had done a specific rare brain surgery without a full clinical visit first. Baffling. I mean, that's either a 10 or 0 number. It's not as though, well, we need to know what your condition is before we answer this question about this specific condition. Why? But, you know, so patients need to start to, you know, the patient community needs to start developing some of their own checklists that they can then share with the medical community and say, okay, how about we come up with this where if you check all these boxes, you get 5 stars, whether as a patient or as a doctor. I mean, because I'm perfectly happy to have a doctor review me as a patient too. So, you know.
It's the Uber of healthcare.
The Uber of healthcare. Let Niam talk.
I agree with Casey, and to give you another example from other industry, you know, when you want to buy something off the eBay and you look at the reviews of the sellers, the good thing is that it's not only one 5-star metric about the seller, but it's different metrics about different characteristics of that seller. For example, the first one is about how fast is the shipping for this specific seller. The other one is how exact is the description of the item. When you received the item, was it exactly the same thing that was described online or not? And I think it would be valuable for patients to have access to the reviews that are about specific areas of the medical care. In addition to the things that Casey mentioned, I think one of the ways that patient feedback can be really helpful is on the procedures that, when done, we expect to observe better outcomes. So one of them is the infection control. Although a patient may not be qualified or capable to measure the outcomes, the clinical expertise, but they have eyes and they can see whether or not the doctor is, you know, changing the gloves whenever they come to their bed to do an exam. So that may be a valid measure of the process of the care. That if physicians do good in that, you may expect better outcomes, at least lower infection rates. The other measure that I can think about is the level of communication between patient and physician in specific terms, such as, for example, whether or not the physician discussed all of your medical options with you and talked about the risks and benefits of each of them and helped you to make a better decision about, you know, which option to go with. Finally, you know, coming from a health IT area, I would say the other measure is to ask patients whether or not their doctors reviewed all of their previous medical records or decided to go ahead and reorder all of those tests again. So all of these measures are about the process of care. They are not about the outcomes of care. However, I think the physicians and medical providers who do good in these metrics are logically expected to experience better outcomes in their care.
Amen. No, the issue for me around patient reviews, as it which is what started this whole party, is that patients' expertise is not in like the drill in the absolute across the board outcome. The only outcome they know is their own, and without working hard on the doctor side to understand what the patient's preference is, what their view of a positive outcome is, and what they are seeking from this exchange. If one side is blind to the other's wishes or the other's intentions, then you're going to end up with a less than desirable outcome, probably. Now, I don't know if either of you, well, I'm pretty sure David does, and I'm sure that Niam probably does too. But are you aware of the Preferences Lab at Dartmouth?
Yes.
Okay, well, Glenn Elwin is, he's a colleague of mine, a buddy, and I think that we need to make knowledge about the availability of the tools that they're working on a lot wider than it is now. I mean, it's starting to happen over time, and I'm, helping work on a BMJ paper. Well, not right now because I'm talking to you, but in general, I've been working on this for weeks, months actually. And I mean, I'm just a tiny little voice. So yes, I agree. But at the same time, my name's going to be on it. Yay. But this is where the change is going to happen. This is where shift will really occur. Is if patients are given the ability to fully connect with all of the parts that are under their purview, not as though the surgery is, but that, yes, we trust our clinicians, but if the clinician doesn't ask, what do you want to end up with out of this? Other than, dead, not dead. Well, okay, let's start there, but there's other pieces in the middle here, and that's where we've got to do more work on both sides. Patients need to be more pressing about, like, here's what I think, this is what I want, and doctors have to be willing to listen and then work with that.
This is great. Well, I want to thank you both for engaging in this conversation, and we've addressed a number of the questions that have popped in over the course of the hour. And I think that as we're wrapping up this hour, we've identified a couple of different kinds of resources that I'm hoping that we can share amongst the three of us and then share more broadly in order to start a broader conversation about what are the things that we need to be thinking about, what are the things that we need to be looking at in order to ensure that there is an appropriate level of patient-provider communication so that we can achieve quality outcomes. And I'm circling back now to Niam's point earlier on that most of health or healthcare even is experienced outside of the doctor's office. So it's really a partnership. It's really a partnership that we need to be able to describe better. We need to be able to assess better. There are a lot of pieces to that, and I'd like to start sort of collecting those resources so that we can better describe and evaluate that partnership and the quality outcomes that will result. I want to thank my guests, Niam Yaraghi.
I'm just going to raise my hand with one
yes,
thing.
ma'am.
Niam, given the work that you're doing at Brookings, I will say in public, and this is for posterity, that at any time, if you need anyone from the patient community to weigh in, give you, either a gut check, be a crash test dummy, etc., an idea factory, anytime you want the patient community to get involved, just ask, because we're here. And boy, do we care. And the fact that you're willing to listen. No, I mean, I consider you a friend. I know that we were kind of like, it was like gloves on, steel cage match. some people, I think, took that, but this whole thing happened because I called you. You've got your phone number on your website. I do too. But you answered the phone, and we had we talked for half an hour, and I have a lot of respect for what you're doing, and I see you as one of the solutions, not in any way an obstacle. So if you want to build something, I'll help.
Thank you.
Excellent. What a happy ending. I'm glad that we've had this opportunity to have this conversation together, and I take this as not the end, but just a beginning of future collaboration, and I look forward to great things as a result. I want to thank my guests, Casey and Niam, and everyone who's been hanging out with us today. And I invite all of you to continue this conversation with us. As I said, I'd like to post some of the resources we've been talking about, and we're going to post an archive of this Hangout online. And you know where to find us. So thank you very much.
Thanks for having me.
My pleasure.